Okay, good morning, everyone. I looked at the schedule, and I've done at least 3 talks on opioid-induced constipation. I know there have been some others. I did a talk on adverse effects of opioids, which included opioid-induced constipation. So hopefully much of this stuff will just already reintroduce constipation, what a burden it really is to our patients and to the healthcare system, and how we have new FDA-approved therapies that should really supersede over-the-counter laxatives, which, as you'll see in a few minutes, really lack significant efficacy for many patients. It's supported from an educational grant by Salix Pharmaceuticals, a division of Valeant, as well as Consultant, a registered trademark of HMP Communications. Okay, so finding relief from OIC, individualizing therapies. For those of you who I haven't met, I direct a pain and palliative care program in northern New Jersey. It was formerly one of the Mount Sinai affiliate hospitals. We're in the process of academically collaborating with a new medical school that's in New Jersey. I do a fair amount of teaching, research, writing. You can imagine that I'm relatively desired by the manufacturers of these products to help with educational activities, to help with clinical trial design, to help with publication strategies. So I do a fair amount of consulting for the pharmaceutical and toxicology industry. Hopefully by the end of this talk we could understand the prevalence and burden of OIC, as well as some of the barriers that patients face. I'll talk to you about the latest in screening criteria. I'll give you 1 or 2 tools that you could actually take back to your practice, tools that have been recommended by American Academy of Pain Medicine. Evaluate the full treatment armamentarium, so I'll go through with you what some of the more common stool softeners and laxatives are, but I'm going to focus today on what the FDA-approved therapies for OIC actually are. Talk a little bit about their mechanism of action, which I think you've probably heard a few dozen times at this point. And again, I'll go over some of those consensus recommendations. All right, so some of the key points. For some unknown reason, and I've been kind of interested in OIC for about a decade already, still can't figure out why there are so many millions of neurons in our gastrointestinal system. Did anybody go to the lecture on the microbiome? I think that might have been Tuesday morning. Was that unbelievable, that talk? Right? Sometimes you leave a conference and you only remember one talk. For Pain Week, for me, that might be that one, right? You look at everything you eat differently. Even though I was still eating pretty bad this week, I just knew it was bad for me as I was eating it. How you have this microbiome in the gut, and it's so closely interrelated to the immune system and your nervous system, right? How the nerves transmit from the gut to the brain important information. And I can tell you, I'm not a sugar guy, and if I sit and have a sugar thing, I'm that sugar coma guy. I feel blah, I feel kind of yucky, my head starts to bob, and I just know sugar kills me. And certain other foods as well. So for some reason, we have this nervous system inside our GI tracts, and we don't really still have a full understanding of what it does. But when you take so that nervous system has just as many, if not more, opioid receptors, especially mu-opioid receptors. So when you take an opioid that's targeting the analgesic structures in the CNS, the brain and the spinal cord, it actually binds just as much in the gut as it does in the CNS. When you do that, you activate certain physiological processes that I'll talk about in just a moment. And one of the basic tenets of the newer classes of medicines is, hey, we have opioid antagonists. Why couldn't we just design an antagonist that doesn't cross the blood-brain barrier and stays out only in the periphery? And that's exactly what they did. They designed these big, bulky molecules, charged and polarized and side chains that don't cross through lipid bilayers like the blood-brain barrier. So it keeps them outside the CNS. If you were to get them inside the CNS, your patients would withdraw from their opioids. But they're antagonists that stay outside the CNS. So, not to belabor the point, the analgesic effects of opioids are in the brain and spinal cord. Constipation is mediated by those in the gut. Take any package insert. I didn't mean to pick on oxycodone, but when you look at adverse reactions in clinical trials, around 20%. When you survey patients, probably 40%. Although you could find 40 to 90% incidence of constipation on opioids. By the way, in future years, you're going to hear more about some of these other side effects because they're trying to develop medicines for OINV, opioid-induced nausea and vomiting, opioid-induced pruritus, opioid-induced dizziness, those kind of things. So right now we're focused on constipation because it's one of the more common adverse events. All right, so Why are we talking about this 5 or 6 times in 1 week at a pain meeting? Because in recent decades, with such a rapid rise in the prescribing of opioids, we've had a concomitant rise in the incidence of opioid-induced constipation. So we need to think about treating it. 40 to 90% when you look at the literature. And here's one thing I don't think I mentioned the other day. If I start a patient on an opioid and they get itchy or sleepy, even sometimes sweaty, I say, you know what? Lower your dose, hang in there if it's giving you relief, and let's titrate slowly over time. And they get used to those side effects over time. Constipation is not one of those side effects that they develop tolerance to. So I have a patient, on opioids for 22 years at this point. They've been constipated for 22 years from their opioids. It doesn't go away. It remains a burden on patients and the healthcare system. So when you look at the literature, it's hard to believe, but constipation, well, it's easy to believe how it impairs your work impairment, but contributes to absenteeism. People have more hospital admissions, longer stays if you're an inpatient than if you don't have OIC. You talk to the ER docs, they'll tell you they see opioid-induced constipation all the time. I mean, who would have thought? Patients go to the ER because they can't poop, and it's painful. I think I might have mentioned the other day, I had one patient said he wanted to kill himself. He said, Doc, I've been hit by a truck. I had 6 belly surgeries. I mean, I've had no shortage of painful things in my life. This was the worst pain I ever had. Feeling of being stuck, squeezing so hard, sweating, parasympathetic outpouring. He said it was terrible. He called the ambulance and went to the hospital. Here, if you look in the literature, people missed time from work. They were impaired at work, and they had activity impairment. And when you talk to people who suffer with constipation and they do the roller coaster of over-the-counter laxatives, they're afraid to get on the train in the morning. They're afraid to get in the car. They watch the traffic report, because if they're not timed exactly right, leads to an accident, and not a motor vehicle accident, but I guess if they have one accident, it could lead to another accident. So when you take an opioid, it has certain physiological effects in the gut. It slows your transit time. So I talked a little bit about this the other day. Taking you all the way back to anatomy and physiology, if you remember, the bowel wall is made up of different layers of muscles, circular muscles and longitudinal muscles. And throughout those muscle layers are different plexi of nerves, the submucosal plexus and the myenteric plexus. And when the opioids bind to those mu receptors in the neural plexuses, it turns off the circular muscles and it turns off the longitudinal muscles. And what the circular and the longitudinal muscles do in concert is this. Squeeze, 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 squeeze. So it's a rhythmic contraction that propels the stool along the intestines to get it from the top down to the bottom. So you interrupt that synchronous gut movement, and it might still contract, but it'll squeeze once here, squeeze once here, squeeze once here, fibrillate a little bit here. You lose that kind of orchestrated response. 2 things happen to secretions. Less comes out, so you get less secretion into the, less secretions that come into the lumen, and more resorption of water. So now the stool is not moving, no more secretions are going in, more water is being drawn out, and your sphincters tighten. All of those things are what we think contribute to this concept of constipation caused by opioids, or OIC. What do your patients say? If you say, are you constipated? Patients might say no, because they don't equate straining, bloating, pain with bowel movement, incomplete evacuation, hard stools with constipation. So there's a couple of guys who have made their career on coming up with definitions which they kind of update every couple of years as to what constipation is, and I'll share that with you in just a second. It's probably the most common side effect of opioids. 1 in 2 patients, I told you the data before. 1 in 3 doesn't discuss constipation symptoms with clinicians, so we need to figure out a way to kind of drag this out of patients. Hey, if this is affecting your life, we have remedies for this. You don't have to suffer with opioid-induced constipation. So Mike Camilleri, I think he's at Mayo Clinic, has been kind of spearheading a lot of GI and pain group consensus meetings to talk about what really is constipation related to opioids, or OIC. And the best definition they've come up with so far is a change, right? It has to happen after you start opioids, or it's not opioid-induced constipation. A change from your baseline after starting opioids that's characterized by either a reduced frequency, less number of bowel movements, and I'll show you the clinical trials in a second. That's their primary endpoint. How many bowel movements per week are patients having? Worsening or straining to pass bowel movements, incomplete evacuation, or harder stool consistency. Anybody remember from one of the other talks, how many bowel movements per week do patients have on average that are on opioids? 1.5, that's right. 1.5 bowel movements per week. Kind of scary, I think. All right, this is my patient now for, well, I bet you she's been with me 15 years. Here's her history. She was a nurse or a nurse's aide. She had a low back injury. She retired from her job. She had a couple of spine fusion surgeries, and like most in the practice, I mean, if they did well, they wouldn't be in the practice. She failed her surgeries. She's been going back and forth to figure out whether she should actually have neck surgery as well. She's got bad left shoulder pain. She's on transdermal fentanyl 75. She takes hydromorphone 3 times a day as needed for pain. She sometimes goes above those 3 times a day, and we've had lots of talks in the past, but she really seems to be suffering. She's got hypertension, hypothyroidism, some irritable bowel syndrome, with a history of bowel obstruction on opioids. She perforated her bowel. A month in the hospital. Open belly. I don't know if you've ever seen these things. They can't close the belly because the peritonitis is so bad and the bowels are all distended. Open belly with those rubber shod things. She spent 1 month perforating from constipation. Right. So this is an extreme case. She says that her bowel movements have been less frequent since she started opioids. She didn't talk about changes in bowel habits with her previous doc. She says over-the-counter laxatives are useless. Docusate and Senna, she'll take 12 of each a day and really get nowhere. And we start to talk about the laxative overuse syndrome. So there are some baseline risk factors for constipation, let alone opioids, right? Because a lot of people have constipation. Female gender, advanced aged are some of them, dehydration, nutritional deficits. Clearly, hopefully some of you have recognized in yourselves that diet means a lot, hydration means a lot. Travel, you travel someplace, next thing you know, you're not pooping for a couple of days. Drug regimens, this is a very common one, not just opioids, the antihypertensives, anticholinergics, the psych drugs, antihistamines, calcium-like agents, the TCAs, especially in a pain practice. And immobility, recent hospitalizations, those kind of things. So, are there tools that we could use to measure and monitor opioid-induced constipation? That's actually my hand on my step in my house. I said, I need something that looks like, how can I measure something? I couldn't find a good Google image, so I took that picture. All right, so there are a number of tools as clinicians that we could use. I'm going to show you in just a second. This I have hanging in my waiting rooms. It's basically a poop poster if you haven't seen it. It's the Bristol stool form scale. And it shows, you ask the patients, hey, look at this, and they get the first time they look at it, they get a chuckle, but by the 10th time they see it, they say, no, I'm a number 3 now, I'm okay, or, I'm doing all right. So one is the little, rabbit pellet, mouse pellet, little balls of poop that come out just dry and hard. 2 is that, oh God, you can't believe how big it is. It's like a big lumpy sausage kind of shaped thing. And it goes all the way down to watery, stools, no solid pieces, etc. Some of the research studies use this PAC, Patient Assessment of Constipation. There's actually 2 parts to it. One is the symptoms of constipation, which I think this one is. The other is a quality of life. This is a little more difficult for the everyday clinician to use. We met with American Academy of Pain Medicine to decide what tool would be really easiest for clinicians to use, and how should we use that tool to decide on when prescriptive therapies should be applied. And we decided on this one, the Bowel Function Index, which I'll go over with you in just a second. It's 3 questions about ease of defecation and your overall feeling of constipation. You grade them 0 to 100, you add them up and divide by 3, and anything greater than 28, for ease of sake, we said anything greater than 30 should trigger a response from you that if the patient hasn't maximized conservative therapies, to consider prescription laxatives. All right, so here's that Bristol stool scale, right? Kind of weird, but we ask patients, hey, point to it. What does your poop look like? Here's the PAC question. It asks about bowel movements. Focuses a lot on rectal and abdominal symptoms. This they use in research, and they give patients a diary because they have to remember back 2 weeks. And we figured when you ask normal people what were their bowels like 2 weeks ago, I mean, I'm a pretty sane guy with a good memory. I couldn't tell you what my bowel movement was like up to 14 days ago. So we figured this would be hard for the general patient, so that's why we decided in this consensus group, which was published in Pain Medicine, that we should use the BFI, that tool with 3 questions, and anybody greater than 30 should have a response, a prescriptive response. So again, 0 to 100, it asks 3 questions. Tell us about how easily you defecate. Do you have a feeling of incomplete evacuation? And overall, how would you judge your constipation, 0 to 100? Add them up, divide by 3, you get this is a very easy tool, and it's only 7-day recollection, so it's a little bit easier than 2 weeks. So Susan scores pretty high on her bowel function index is 71. Her Bristol stool form is the top of the poster, type 1 and type 2, hard and little balls. She has infrequent bowel movements with pain and straining. Someone else told her, hey, you should increase your fiber and drink more water. Now let me ask you a question. What do you think happens to patients with constipation who lost their contractility and take lots of psyllium husk or metamucil or fiber? They get a big, bulky mass of cement that doesn't propel along the intestines. For you or I, for a little functional constipation, bulking is good. The bowel likes bulk. It senses the volume, and it actually stimulates contractility. But for our patients with opioid-induced constipation, I tell them never to bulk. Bulking is a bad idea, unless, of course, they have some functional constipation, then it helps them as well. She's using Docusate and Senna. She says they're relatively useless. For her, she says, I'll try what I try first. And we hear this from patients all the time. First, I try a fried egg, is what she says. Some patients will say, hey, I warm my orange juice. Or you know what really works for me? Potato chips. Some people have that food that just stimulates their intestines to go. So I always try to ask patients about that. She is using our latex gloves to manually disimpact when she needs to. And believe it or not, I started to ask patients about that. You'd be shocked how many patients manually disimpact their bowels. If we don't ask, we don't know. Right? These are the side effects of our medicines. She's had severe abdominal pain related to constipation. I told you about her story with perforation. And here's the typical example that her constipation has been so bad, she takes off her fentanyl patch, she goes into withdrawal, she has diarrhea, she evacuates her bowels, her pain is horrendous, and then she puts her patches back on. Right? That's not a way for pain patients to live. So, here are all the things that if you think about what can we do other than prescriptive therapies. Hydrate. I listened to a guy overseas. I did a talk on constipation at the World Congress of Pain in Vienna a couple years ago, and a really bright GI doc said, what is this thing with hydration? We probably have, 50 liters of fluid throughout our intestine. What's another 1 or 2 liters going to do? And you're putting it all in up top. What's making it down to the colon? He's like, there's no evidence that hydration really works. But you know what? It makes sense to us. You don't want to dehydrate. So we always recommend hydration. Fruits, juices, caffeine, and fried foods do it for some people. Again, I try to avoid bulking agents for OIC. Exercise is one thing that is known to help, especially anything that flexes your abdominal muscles. So it's hard to get pain patients to exercise, but I say, hey, here's it. Not just simple walking, unfortunately, but getting anything to move the core. I'll come back to obey the urge in just a second. Manual maneuvers we talked about. Positional. I might have said this the other day. Just before I left the house in New York last week, we got the Costco flyer for the month of September. They're selling 2 squatty potties for $40. Right? Anybody see the squatty potty? Hey, get your legs up, right? When you go to move your bowels, get your knees up. Changes the angle of your pelvic floor muscle, lengthens the levator ani, lengthens the rectum, makes it easier for the stool to come down. And when you look at the data from the Far East and African countries where they don't have toilets the way that we have and they squat to poop, they have less constipation, less hemorrhoids, less rectal fissures, easier to poop. It's not such a big problem as it is in the Western world. So position can help. And then bowel hygiene, I may have mentioned this the other day as well. I tell patients, obey the urge. And just so you know what I'm talking about, it's 9 o'clock a.m. You pick up your first chart off your rack, and you're about to go in to see the patient, and your belly goes rumble, 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 rumble. And you stop for that millisecond, and you think, you know what? I could probably go to the bathroom right now if only I had the time. And you don't have the time. You ignore the urge. That urge might not come back at all till tomorrow or the next day at the same time. So I tell patients, if you get the urge and you're in a place where you can take advantage of the urge, take advantage because it may not come back. All right, so in general for constipation, adequate fiber, adequate water, regular exercise, laxatives, stool softeners. And I learned 25 years ago as a fellow at Yale in the pain center from one of my nurses, Hannah, said, listen, every single patient that you write an opioid for goes home with Senokot and Colace. Every one. Or else you're going to be fielding the calls, you're going to be doing the disimpactions, et cetera, et cetera. So if we prophylax patients, they're less likely to experience constipation. What are some of the more common agents? Stool softeners. Some of the experts think that this is like placebo, but when you talk to some patients, anybody know how Docusate works? Like soap bubbles. It's like lubricates the bowel. So some patients say it's relatively useless. Other patients say, look, it works great for me. I take it. So we still recommend it. Stimulant laxatives, the natural one like Senna or bisacodyl or things like castor oil. One of the more common ones we're using now, polyethylene glycol, Glycolax, Miralax, those osmotic-like laxatives. Lactulose, for me, in the day, this was probably my go-to laxative, although some people couldn't stand the taste. There's lubricants, bulking agents we talked about, enemas we try to avoid unless absolutely necessary. So, how satisfied are you with the efficacy of OTC therapy? I'll tell you, when you look at the clinical trials of patients who enroll for opioid-induced constipation trials, they're on 1 to 2 laxatives without benefit. So I would say at least half of the patients don't get benefit from over-the-counter laxatives. So I'm not all that satisfied with laxative therapies. In addition, they don't prevent or treat the cause of opioid-induced constipation, right? You've activated your mu receptors in the gut. That's why we're going to talk about those mu receptor antagonists in just a moment. I said 50% of patients, 50% of the time, respond to laxatives, and clearly there's laxative overuse syndrome and electrolyte abnormalities and issues that can come from abusing laxatives. So Susan takes Glycolax, polyethylene glycol with breakfast. She takes 3 Colace in the morning, 3 Dulcolax before bedtime. 6 weeks later, she says, well, I am a little bit better. We do her BFI again. She went from a 71 to a 63. Remember, 28, above 28 is considered constipated. She's still a mostly type 1, but some type 2. Bowel movements are a little better, but she's still straining them. So she's not better from a constipation standpoint. So she's had an inadequate response to therapy. What's our next decision? Well, we need additional treatment options, which, thank goodness, over the last decade we have. The FDA has approved medications for opioid-induced constipation. Currently, they're of 2 classes, although there are 2 more classes I'll tell you about that are seeking indications for opioid-induced constipation. As you can imagine, industry, the pharmaceutical world, is very interested in this space for business reasons, right? They're trying to develop new molecules to treat the side effects of drugs. So, hopefully, at this point in Pain Week, if you've been to some of the other talks, you know what a PAMORA is. Peripherally acting mu-opioid receptor antagonist. It's like Narcan that doesn't cross the blood-brain barrier. Doesn't put you into withdrawals. It doesn't minimize analgesia. It just unbinds or blocks the opioid receptors out in the periphery. We have 3 of them currently approved, 2 of them currently launched. Methylnaltrexone, Naloxegol, and Naldemidine. We also have another one that met its primary endpoint for opioid-induced constipation, and that is a prostaglandin-like drug called Aprostone or Lubiprostone. It actually opens up ion channels. Believe it or not, ion channel modulators are a very exciting area of development in all areas of medicine, not just in pain and constipation, neurology and cardiac, etc. But in the gut, when you open chloride channels, as I'll show you, and let me just see in just a second, I'll show you in just a second, chloride flows into the lumen of the bowel. What follows ions is usually other ions, sodium and potassium and water. It lubricates the bowel senses volume, and contributes to a bowel movement. Now, what do you think happens when you send water into the lumen of the colon? What's probably one of the more common side effects? Diarrhea, and that's what we see with this class of drug, although it does work for constipation. So, here are the 4 currently approved therapies. I'm not going to go through each of the details. They're all oral with one exception. Methylnaltrexone has both a subcutaneous and an oral formulation. This was the first one that we used for the last 10 years. We only had it in subcutaneous form. And as a palliative care doc, we have a lot of cancer and advanced illness patients that we would use this on in the hospital setting. So there's an injectable dose. It's usually 12 milligrams, 8 if you're cachectic, or if you're super lightweight or super heavyweight, there's a milligram per kilogram dosing. It's the most recent one to launch in oral tablets. It's 3 tablets, 150 milligrams each, gives you 450. Naloxegol was the first oral preparation that we had. It comes in 25 and 12.5. As I'll show you in a moment, the FDA-approved dose is 25 milligrams per day, with 12.5 reserved for those patients with advanced renal disease or those patients who hyper-respond to 25. And the newest one, which was approved but I don't believe has launched yet, is called Naldemidine. All 3 of these work in a similar fashion as PAMORAs. You'll see in just a moment that they all did their studies just a touch different, and there's some nuances to each one about how they're metabolized that I'll try to review with you real quickly. The injectable methylnaltrexone had the indication for palliative care. All 3 of the orals have an indication for chronic non-cancer pain, opioid-induced constipation. Lubiprostone, they say take it with food and water, low likelihood of drug-drug interaction. I told you before, diarrhea is a problem, nausea. For some reason with lubiprostone, they get this feeling of dyspnea. It's not hypoxia. They have a dyspneic feeling, so some patients will not tolerate the medicine. The instructions for methylnaltrexone say you need to take it on an empty stomach at least 30 minutes before the first meal of the day. Naloxegol comes with a warning about the P450 drug-drug system. Also says take 1 hour before or 2 hours after meals. The label was updated recently to say the tablet could be crushed to a powder and mixed with water and drunk, also put through an NG tube, so various modes of administration. Naldemidine also has P450 and some P-glycoprotein inhibitor warnings, right? So little nuances between the few. You should learn about one of these drugs, learn the nuances, and figure out how to best use them in your practice. So I explained lubiprostone activates chloride channels. Patients don't seem to become dependent on this drug. When you open up the chloride channels, chloride flows in, sodium flows in, water flows in, unlikely to cause electrolyte balances. Its big approval in the GI world is for irritable bowel syndrome with constipation, but it also met its endpoint, to me, not all that impressively, but for opioid-induced constipation, which is why it got its approval. For those of you interested in data, this is published. You could find it. They did what was the change in frequency of bowel movements at the end of 8 weeks in their phase 3 clinical trial. And as you could see, it met, I don't know how they got this, it was statistically significant at week 8. It was not statistically significant at week 12, but it was overall, and it did get approved for opioid-induced constipation. The PAMORAs I mentioned before, opioids in the brain and the CNS give us pain relief. Opioids in the gut give us constipation. The peripheral action of these agents stays to the gut, doesn't get into the brain, and reverses the constipation. The 3 that are available, methylnaltrexone, I told you, originally injectable, now oral. Naloxegol, approved in 2014 for non-cancer pain, the first oral formulation of a PAMORA. Recent label indication it came out only for non-cancer pain, but the label now says you can use it in patients with chronic pain related to prior cancer who don't require frequent opioid dosage escalation. And the same wording is for Naldemidine, the most recent one that was approved. By the way, these drugs are structurally similar to opioids. If you look at the structure of naltrexone or naloxone, it looks like an opioid, even though it's the antagonist. So when these drugs come out and get FDA approved, because of their structural similarity to opioids, even though they're antagonists, they get scheduled by the FDA as Schedule II drugs. This is a pill for constipation that doesn't cross the blood-brain barrier. There's no abuse or addiction potential that we know of. So the companies first have to go through a process called descheduling. They have to get the drug unscheduled. So even though it's been approved, this third agent here has yet to launch because it's still a scheduled drug. And if they came to your office and said, hey, we have a new pill for constipation, but it's a Schedule II, you got to write it like you write an opioid, you'd be, well, that's kind of crazy. So they figure it's probably just easier to wait until the scheduling comes away. Again, some nuances of each one. I'm not going to take you through the details of each of the clinical trials, but rest assured they were all done randomized, double-blind, placebo-controlled studies. All have oral formulations. I mentioned before they're all indicated for chronic pain and non-cancer or previous pain related to previous cancer. Recommended doses of the oral naltrexone is 450 milligrams. Recommended doses of the injectable methylnaltrexone is 12. I'll show you how that's going to differ based on weight in just a second. Naloxegol, 25 milligrams once daily. If you can't tolerate it, go down to 12.5. If they have creatinine clearance of less than 60 or 30, I can't remember, you can go to 12.5 as well. It's probably a good idea to discontinue maintenance laxative therapy before you start this drug. Because I've had some, before you start any of these drugs, even though the labels are a little bit different, because I've had some hyper-responders. And if they're going to hyper-respond and be on stool softeners and laxatives, they get a hyper response. So I like to stop their stool softeners and laxatives, start them on the prescriptive therapy. Clearly, you shouldn't use this in patients that have the potential to perforate their bowel wall, right, where the integrity of their bowel really isn't full. So anybody that's suspected obstruction, patients at risk for perforation. Real quick, this is the methylnaltrexone injectable study, 12 milligrams versus placebo. They looked at what percentage of patients have at least 3 spontaneous bowel movements during this 4-week study period, and it met its endpoint. All right. All of the side effects, most of the side effects for all of these agents are similar. If you're not moving your bowels, and now we're going to give you a medicine that's going to kind of stimulate bowel movements when you've been so constipated, think about what your side effect profile might look like. Abdominal pain is number 1. But even though they got abdominal pain, the dropouts in these clinical trials were low, suggesting that it was tolerable abdominal pain. Nausea, diarrhea, hyperhidrosis, flushing, tremor, chills. So I'd mentioned we had the injectable methylnaltrexone. If you look, I think earlier this year, published in Pain Practice, was the article supporting oral methylnaltrexone for patients with chronic non-cancer pain. And some of you may have seen Rick Rauch and I did a talk just the other day here at Pain Week. Let's talk about naloxegol. So naloxegol was the first orally available PAMORA of its kind. The FDA says when you want to get approval for a drug, you need to give us 2 studies that have positive outcomes. So they designed 2 identical studies. These were called Kodiak 4 and Kodiak 5. And they looked at, these are 12-week studies, double-blind, placebo-controlled, obviously. And they looked at what proportion of patients had 3 or more spontaneous bowel movements per week with at least an increase of 1 more bowel movement per week than what they had from beforehand. And it had to have duration, at least 9 of the 12 weeks of the trial and at least 3 of the final 4 weeks. This drug had to work and keep working. And I'll show you from the data here that in both studies, they met statistical significance for the 25 milligram dose. So when you open the package insert for naloxegol, it says the dose is 25 milligrams. There's a numeric improvement at 12.5, but in one of the 2 studies, it just missed statistical significance. So they couldn't put in their label, both doses are the approved doses, 12.5 and 25. Only 25 is in the label, but you can use 12.5 in face of hyperresponders or renal dysfunction. All right, I'm clearly not going to take you through the data, but you can see here, I showed you the data for methylnaltrexone. Here's some side effect data for naloxegol. Same thing goes, right? Abdominal pain, diarrhea, nausea, flatulence, vomiting, GI symptoms. This is a GI active drug. We wouldn't think about anything different. All right, future therapies in opioid-induced constipation. Overseas, and we even have it approved in this country, but it hasn't been launched, is a combination oxycodone-naloxone. Picture OxyContin with naloxone in there. You might say, well, why would you put an antagonist in with an agonist? Well, it turns out that naloxone is very poorly bioavailable, but a little bit does get in. And what they figured out is when a little bit gets in, it actually counteracts the bowel effects of oxycodone. So here we use OxyContin, or its equivalents. Overseas, they're using an OxyContin naloxone product. And overseas, it has the label for reducing bowel incidence. There are agents in clinical trials that I mentioned to you before, things like uroguanylin analogs. Who the heck knows what that is? Well, it turns out that there are a lot of different chemical pathways that control gut function. Guanylate cyclase C activators. This works a lot like the prostones that I told you before, increasing flow of ions into the bowel wall. Remember from pharmacology or physiology, there are serotonergic receptors throughout the GI tract. There's other prostaglandin-like drugs that are in development and other PAMORAs that are in development. So you're going to see in the future newer types of therapies that come out for this particular problem of opioid-induced constipation. All right. Remember, there's no tool that replaces communication with the patient. First of all, I want to thank you guys for coming. This has really been a great pain week for me. I'd have to say one of the best. We've learned a lot about opioids, but also this week a lot about new things on the horizon. One of my favorite talks was my new analgesics or future analgesics that we did this week. But for now, we have analgesics. Constipation is one of the most common side effects. It doesn't get better over time. Patients don't usually convey how bad it is. Stool softeners and laxatives that they use over the counter are often not appropriate or effective. We have newer prescriptive agents that are available. Managed care is a bit of a barrier, but there is better access to these newer drugs. Pick one or two. Learn about them. Learn the nuances of prescribing and some of the indications and contraindications, and don't let your patients suffer with constipation. Tools available for you to use. Go online. There are certainly lots of tools like some of the ones that I talked about. Make sure to educate your patients about constipation, discuss prophylactic treatment, coordinate with other family members who's going to keep on top of this, and we'll stop right there, take 2 minutes for questions.